in-hospital patients actually have things like cardiac arrest for entirely different reasons for the ones that have it outside hospital. Patients in hospital, patients who are actually an inpatient, they deteriorate from an underlying disease process. And many cardiac arrests, for instance, are eminently predictable long before they actually happen. We need to prevent their loss of consciousness if we can, rather than actually treat it. I wanted just to mention briefly on the topic of deterioration, because it's such an important thing, and it's become such an important topic nowadays across not only Australia but the world, that we should just very quickly revise a little bit of this. Normal function and compensation, we're built to compensate for things, okay? What we're built for, our primary purpose in life, probably other than the opposite sex, is perfusion. Our primary purpose of our entire system is to perfuse that reticular activating system. And we do that with our respiratory system, we do that with our cardiovascular system, which work together in that sort of integrated way. We can't separate them out. But if you actually look at some of the evidence around people who have deteriorated, what you can see is you can see evidence of deterioration in all those different systems long before they actually get sick. And the clinical signs of getting sicker and heading towards unconsciousness and collapse are the same no matter what the underlying process. Physiological observations, this is a particular bugbear of mine, and my junior doctors in emergency departments get sick of me telling them about actually use your eyes and your watch and your ears, because even in this era of fantastically complicated machines, what's still a lot better is our level of consciousness and our ability to process the simplest of things. And spotting a trend, which is usually 3 or more of something going in one direction, enables us to actually spot something happening long before it actually happens. This is a classic observation chart from hospital where basically this came out in a study called the soccer study, which was actually a world-renowned study and was done by people in New South Wales by a gentleman who was an eminent anaesthetist and resuscitator. And he showed basically that 50 to 80% of sudden cardiac deaths in hospital are not that sudden, and you could spot them beforehand. And that if you actually looked at some of the observation charts that were done in the hospital, you had an increasing respiratory rate in these situations for hours beforehand, which was religiously documented. Nobody was told about it. And that the heart rate was consistently going up over 9, 10, 11, 12 hours. And the blood pressure eventually was going down. But of course, blood pressure goes down late. But out of hospital are quite different. Collapse and cardiac arrest occur quite suddenly. And they're usually the function of something quite different. They're usually the function of an acute coronary syndrome and usually a dysrhythmia, which occurs VF or VT if they're lucky, because at least that's shockable, and sometimes another sort of dysrhythmia. So what do we need to do about this?
Say some geezer collapses in front of you. What do? We need a volunteer that ain't breathing. Here's one I made earlier. First thing you do is you check him over. If he ain't responsive or he ain't breathing, or he's making noises like this, then his heart will stop working, he's having a cardiac arrest. Look lively. First call 999. Then you do hands-only CPR and no kissing. You only kiss your missus on the lips. Watch. Lock your fingers together, knuckles up. Then push down, right on the sovereign. Push down 5 or 6 centimetres. That's about 2 inches in old money. Push hard and fast, about 2 times a second, like to the beat of staying alive. Worried you'll hurt him? Better a cracked rib than him kicking the bucket. Keep this up till the ambulance arrives. So don't forget, check him over. Call 999, push hard and fast to staying alive.